Hi class, in this recording we're going to be focusing on some of the more specialized movements associated with synovial joints. So as we look at our trunk can be, well, kind of complicated at times. We can have a lot of degrees of movement in our trunk. So as we're looking, let me switch to the pen mode here. Oh, crud. Give me a second here. Back, go back. There we go. Awesome. I am smarter than my computer officially. So here we can see the trunk. And if we bend the trunk primarily at the hips or the pelvis, and we make this so that we are moving the head towards the feet, that's known as flexion. So if we bend the waist or the neck towards the anteriorly or forward, that's going to be flexion. Extension is when we straighten out the trunk or neck. So as we go back to, let me clear the screen here. If we go back to standing straight up and down, that's extension. And if we pass beyond standing straight up and down, so now we've gone beyond, we're leaning backwards. Leaning backwards is going to be hyperextension of the neck and or trunk. Now we also can have lateral flexion. Lateral flexion is when, if we have our anatomical position, would be right, let me clear that. I'm bad at drawing straight lines with a computer mouse. So there's the resting state. And now if I take the body and I bend it laterally or to the side, either to the left or right, we could have left lateral or right lateral flexion. That is going to be referred to as a lateral flexion. And then we also can have lateral extension when we come back to the resting state or the zero position. We could also have rotation of the trunk. So if we look at the trunk, the longitudinal rotation is movement along the longitudinal axis. There's the longitudinal axis of the trunk. This gentleman is rotating along the trunk, his trunk. And then here we have the midline of the neck. And this gentleman is having rotation of his neck either to the left or to the right. As we look at the mandible, our mandible is a tough joint. There's it's a double-edged sword. The funny movements we have with our mandible allow for us to grind, chew, tear, to really masticate the living daylights out of our food. The downside is that a lot of people, myself included, have abnormalities associated with their temporal mandibular joint. They have TMJ, temporal mandibular joint pain. And for me in particular, my TMJ, my temporal mandibular joint will lock up a lot, especially if I yawn really with a big mouth. My mouth will lock up. So as we're looking at our mandible, we can have excursion, and when we think of excursion, we're going to have movement to the right or left from the zero position. So lateral excursion is going away from, when we move the mandible away from the midline of the body, and then medial excursion is when we take that mandible, let me move this out of the way, when we take the mandible and we move the mandible back towards the midline of the body. So in other words, lateral excursion and medial excursion combine to give us the grinding, the side-to-side grinding during chewing. We also can have protraction and retraction. To protract our mandible is to have it stick forward. So instead of having an overbite, you'd have an underbite where the lower incisors, and here's the lower incisor, would stick out more anteriorly than the upper incisors. And then retraction is to pull the mandible posteriorly so that the upper incisors extend more anteriorly than the lower incisors. We also can have elevation and depression, and those really don't need a picture. To elevate the mandible, you go up. To depress the mandible, you go down. Or to use technical terminology, we go superior to elevate, inferior to depress. We also can have some special movements of the hands. Radial flexion of the hand is when we take the hand, or the wrist, and we move the wrist away from the midline of the arm, or the longitudinal axis of the arm, towards the radius. And then ulnar flexion is when we take the wrist and we bend it away from the midline of the arm towards the ulna. And we can't say to the left or to the right because depending on left or right arms, the ulna and radius are either going to be on the right side or the left side. They flip-flop. And then notice with abduction and adductions of the fingers. To adduct the fingers, adduct the fingers, we bring them together. And then to abduct the fingers, we bring them apart. So going apart is abduction. And then we can have flexion and extension of the fingers. To flex the fingers, we curl them up to make a fist. To extend the fingers, we make them straightened out. And every once in a while, typically with younger children that have looser ligaments and tendons, they can even hyperextend their fingers. But that usually will go away by the time they reach adulthood. As we're looking at the hands and digits, palmar abduction is when we take our thumb and we move it away from the digits and hand, and the thumb is pointing anterior. Remember, anatomical position is our reference point. Radial abduction is when we take our thumb and we move it away from the index finger, 90 degrees. So if we were to take that thumb and move it away from the index finger so that we could have our hand, and here's my hand in a mitten, so that we can make our thumb move whoop that direction for radial abduction. As we look at flexion of the thumb is when we take the tip of the thumb and we move it towards the palm. So that direction, towards the palm. An extension of the thumb is when we take it and swing it back out again to straighten it out. Opposition of our thumb is when we take our thumb and we use it to touch the tip of any one of our fingers. And then reposition of our thumb is the opposite of opposition. That's when we take our thumb and we return it back to the 0 position. As we look at our feet, we have other special movements of our feet. Not feet, F-E-E-T. I promise I know how to speak. So here's the 0 position of our feet. And if we take that joint and we raise it upward, we have dorsiflexion, and if we point our toes down, we have plantar flexion. I always like to think that to plantar flex is to try to plant your toes into the ground or to stand on your tippy toes. We also have inversion and eversion. And for those of you that are really big runners and spend a lot of time looking at running shoes, so maybe you're a cross country or a long distance runner track, this is a big one right here. If you're an inverted versus an everted individual when you run, you can have different kinds of inserts put into your shoes. So in a more technical sense, when we think of inversion, we are going to take the soles of our foot and rotate them so that they are turned medially. So inversion is walking on the lateral edge of your feet, and then eversion is walking on the medial edge of your feet. And then you can also buy running shoes based on, or inserts for your shoes, based on whether or not you're supinator versus a pronator when you run. So as we look at supination of the foot, this is a multi-movement term. So if to supinate the foot, we're going to invert, adduct, and plantar flex. So in other words, you are going to be walking, you are going to have most of your pressure applied direct right here. And then to pronate your foot, you dorsiflex, you evert, and you abduct your foot, so that you have this as the lowest point on your foot. So instead of having the anterior lateral margin of your foot as the lowest point when you walk, with supination, with pronation, you have the posterior medial margin of your foot as the lowest point when you have that movement of your foot. As we look at these synovial joints, we have senescence of the joints, as I'm sure we are all well aware, and you probably are starting to experience some of that right now, even though you're probably in your 20s or 30s while you're watching this recording, or at least while you're a university student. And as we're looking at the synovial fluid that's in our joints, as we age, we have less and less synovial fluid, and the articular cartilage itself becomes thinner and or disappears entirely. This increases the amount of friction, both the lack of synovial fluid and the lack or reduction of cartilage increases friction, and more friction means more pain in the joints. As we have that pain in the joints, we have some inflammation, and we have osteoarthritis. This is a fun word here. Osteo means bone, arth refers to the joint, itis means inflammation. So inflammation of a bony joint is arthritis, and it's very real. This is one of those things where it behooves yourself to take care of your body, because osteoarthritis, in many cases, can have its symptoms reduced dramatically, assuming it's not based on an immune system malfunction. As for rheumatoid arthritis in particular, that one terrifies me, because that's an immune system malfunction. Now, as we look at the sternocostal joints, these sternocostal joints, in particular the cartilage is around the ribs, costal meaning ribs, sternum referring to, well, the sternum, that calcium, or the cartilage, can begin to calcify and become much stiffer. And that makes it much more difficult to breathe. You have less flexibility within your thoracic cage. As we look at the intervertebral discs, those are made of fibrocartilage, and they can degenerate. As they degenerate, they can cause back pain and or stiffness. And for the record, back pain is not very well understood. As we look at our herniated discs, people with herniated disc, or intervertebral disc that has bulged outward from in between the vertebrae, can be associated with back pain, and sometimes is not associated with back pain. It's not very well understood at this point. But it is there is a correlation between aging and the degree that we herniate our disc. As we age, the amount of fibers within our intervertebral disc increases. And as we have more fibers, the herniated disc becomes stiffer, and stiffer intervertebral discs are less likely to be herniated. That's all we have for this recording. If you have any questions or comments, please feel free to post them on the class discussion board or to shoot me an email. And as always, happy studies.